This is Pet Life Radio. Let's talk pets.
Hey, welcome to another episode of Vet Candy's podcast in other news. A podcast to expand your idea of what is impacting the veterinary world, veterinarians, and all animal care professionals as humans. We are your co-hosts. I'm Dr. Jen.
And I'm Dr. Jason Chatfield.
If you are not yet a Vet Candy subscriber,
why not?
Please subscribe for free today at myvetcandy.com. You can also reach us at jen@myvetcandy.com.
And for all your positive comments, at jason@myvetcandy.com.
Okay, so our incredible topic today is one of my least favorite things in practice. Not least favorite, but the scariest, which is surgery.
In other news, all vets can become good surgeons.
What?
Yes, I promise you that's the truth.
That's the truth? Well, I can tell you this. Even though I'm the queen of the 45-minute spay,
Good Lord.
I am the queen of the 8 minutes puppies out C-section.
See? We all got to have a role. Good job.
That's right. And then it doesn't take me very long to close those up either because I'm a pretty good sewer.
Is that all it takes to be a good surgeon? Is to be a good sewer?
That's right. That's
Is that
right.
a word?
No, of course
I'm not even sure that's a word.
No.
We better consult someone who knows.
I know. Let's get somebody in here who knows what they're talking about. We happen to have a very good friend, a resident of the Candyverse, and this year's Excellence in Journalism Award winner, Dr. Courtney Campbell. Dr. Courtney.
Oh my goodness. Can you hear me? Can you hear me? I am so happy to be part of this podcast. I cannot believe we're actually going to be talking about literally one of my favorite subjects in the world. So this is a huge, huge day. This is exciting.
It is a huge day because did you hear Dr. Jason?
I did not hear Dr. Jason.
If you didn't, I will repeat. All vets can become good surgeons. All vets. Is this true? Is this true, Courtney?
Can all vets become good surgeons? There is no doubt in my mind that all of them can become good surgeons. I think that at the end of the day, though, that for some reason it gives a lot of people anxiety and makes them a little nervous, and it shouldn't. Because at the end of the day, man, they often say, man, you could teach a monkey to do surgery. I say that's not true because...
I say that.
I would never, ever say that. I would not.
You stole my line, Courtney.
It's disparaging to monkeys. No, I think at the end of the day, the reality is...
Wait.
Everybody, hold on, Courtney. You went on. Did you say that statement is not disparaging to surgeons, but disparaging to monkeys?
No.
That's funny.
Wait a minute.
The reality,
I
the reality
it.
is it's a technical skill. You're exactly right.
Yes.
So the more you do it, the better you're going to become. And I think that is the key.
Mm-hmm.
So, people say, hey, I'm not really good at surgery. I don't really like it. It makes me nervous. And I say, hey, how often do you do it? Well, not very often. Well, that's the challenge there. It's hard to run hard unless you run hard. It's hard to, exercise, strenuously unless you do it on a daily basis. So I think that's the key right there. Consistency makes you good.
And also making friends like you.
Yes.
So we can always phone a friend.
That's it, man. You can't do crowdsourcing on those. You got to phone a friend. And surprisingly, I know we're going to talk about some good stuff. You would not be
crowdsourcing.
The reality of the situation is all those people just trying to do their best in terms of surgery. A lot of times they will be in the middle of surgery, and then you'll get the call. And of course.
Wait! You get the call.
Yeah, you get the call. That's exactly what I was talking about. Not starting a surgery without Courtney on the line. Hey, buddy, I'm about to go in. Hang out for a little while.
Yeah.
You might listen. I'm sure you guys get calls too, but here's the thing. It's lovely because it's a collegial relationship. Everybody's trying to help everybody out, but you get that call right in the middle of surgery. You might be in the middle of something as well. They'll say, hey, doctor, so-and-so's on the line. I'd love, if you could jump on. I said, sure. Why don't we do this? I'll call them back as soon as I'm finished with this one procedure. They say, no. They're in surgery right now.
Right now.
And so you got to jump on the line. And so I always say to everybody, if you're going to jump in a procedure, just make sure you read the procedure beforehand, and then that way. But no, it's fine. I always say that.
Wait, Dr. Courtney, your advice to people is read about the procedure first.
Yeah, get the book first. Get the phone second, but have them both ready just in
And
case.
cut third.
I will say this.
Third.
Listen, and I don't even mean that in any kind of way, like any snarky way. If you are just not, let's say you haven't done that procedure in a million years and you just, oh man, it's been a decade. Don't be afraid to jump open and read the book. I do that all the time, even on procedures that I'm so familiar with, because it just, you can envision things, and it's just, it's wonderful when you read the procedure before jumping in.
Okay, so I have a question. All right. I don't know if you want to share this or not. You could make up the story if you like. I'm going to ask you, like, you can either give us why don't you give us like a biggest, like most common surgical error that you see? And to give you time to think of what that might be, I'm going to give you a little example, for a friend,
For a friend, of course.
Yeah, it wasn't me.
Yeah.
It wasn't me. So I did a foreign body surgery.
You did a foreign body? Or I thought you said this was for a friend.
Oh, no. Well, okay, actually. So my very first bloat, I don't even like to say the word like out loud because it might call it to me, but a GDV, so a gastric dilatation and volvulus for our listeners, which is where like in a big giant dog, the stomach flips over and blows up, right? Or just blows up. And it's a big deal. It's why we talk about feeding deep-chested dogs, like people say, feed them elevated, don't let them eat a ton all at one time, real rapidly, yada, yada, yada. Or basically just get a prophylactic gastropexy, right? And I wish that this Great Dane, who was like almost 200 pounds at 8 months old or whatever he was, had gotten a prophylactic gastropexy because he showed up at my hospital. I had to cut him. First one I ever did. Couldn't phone anybody because it was 3 a.m. Got the book out.
Got the book out.
That's the first step. That's the best step right there.
6 hours later.
Okay. All right.
Wait, that's not normal?
Friends, you can't see Dr. Cordy's eyes just got really big around. He's trying not to judge right now.
I'm not trying very hard.
No, 6 hours later, I was sitting across the room in a chair with my hands up in the air, still gloved, full of everything. The dog was open on the table, and I was thinking to myself, don't cry. Don't cry. Don't cry.
Yeah, 6 hours. It sounds like you might need a snack and a rehydration fluid and stuff.
I did not pack a lunch. Anyway, the reason I can share this story is, it turned out good, right? Dog survived. I figured out. I just had to take the spleen out. Gave me more room to figure out how to untangle the stomach that had gone through a weirdo situation with the omentum. Anyway, whatevs. And it turned out okay. But I would like to never face that again. Because that was like an error because he was so long under anesthesia and all that. And so what about, like, what do you see as like a common mistake? Or have you ever had something where you got yourself in a little over your head or anything like that?
Oh, that's a double-barrel question.
That's how I like to roll.
Let's tackle the second question first. Have I gotten in over my head? Oh, most definitely, where you have evaluated a patient or you've looked at radiographs or you assume, you always get in trouble when you assume.
That's right.
And you just, based upon your assessments, you think that this is the most appropriate action. And then when you start the surgery, you realize this is not what you thought at all. And this is
uh-oh.
Yeah. Fortunately, the majority of those cases tend to be fracture cases where, let's say, there are lines or fracture lines or fissures that you couldn't necessarily appreciate radiographically. Mm-hmm. But then once you get in there, it's a mess and it's really disastrous. Or let's say you're in an abdomen and you discover a mass in there that wasn't found on ultrasound or something like that. I mean, things can get hairy quickly. And when it does, a bead of perspiration starts on your forehead. Your toes start curling. You get this sinking feeling in your stomach. It's like, oh, please, somebody save me.
Right.
That's what we call you.
Yeah,
that's right. Have the phone. Call Courtney.
I want to save myself sometimes. It's wild. So I will say this. Has it happened to the best of us? Of course. And I'm not including myself as the best of them, but I'm saying it happens to everybody. I will say that, for people who get into these situations, 6-hour GDBs and those types of surgeries, all I have to do is applaud you for your perseverance and the fact that everything turned out well. That's what I have to say about that. And
he applauded you for your perseverance.
Yeah, no, you stuck with it. And that's what.
I didn't have any choice. His guts were out.
What was the other choice? Close it up and go home.
I have had that. We'll talk about that another time. But you do. There is something that you two underscore about surgery. You are committed, and so once you start, You've got to finish. And it's something that I don't
That's
know.
right.
I think it's a little bit underappreciated.
Yeah.
And that I think takes that courage that you sort of illustrated during that GDV. It takes courage to get in there and finish the job. So I applaud you. Now, you did ask about mistakes. And part of me was like, oh man, are we going to start off on mistakes?
Yes.
But let's get those out of the way.
Yes,
right
eat the
off
frog.
bat.
Eat the
Yes,
frog.
That's right. I technically like to eat my dessert first, but let's do this. Let's start off with the mistakes. And the first two I'll say right off the bat have to do with the submucosa. And the only reason they popped into my head primarily is because you had mentioned a GDV. So we'll say right off the bat, mistake number one is failure to grab submucosa when you're showing intestine. That is the holding layer of the intestine.
Right.
And when you're, let's say you're not experienced in surgery, you're sort of uninitiated with surgery or closing the intestine, then you may tend not to grab the submucosa. And of course—
Does that mean you're just going too superficial with your bite? You need to go a little deeper?
Yes. So working from inside out, you have mucosa, submucosa, muscularis, and serosa. Yes. And so when you're too superficial, you're just grabbing the outside layer of the serosa and the muscle, but you didn't get the holding layer of the intestine, which is the submucosa. Now, ideally, of course, you don't want the suture to go into the lumen of the intestine, but if it does, at least you know you grabbed submucosa and you've avoided something absolutely disastrous, which is leakage or dehiscence of your intestinal incision. So again, let's try to keep the suture out of the lumen. But if you can't, that's okay because you grabbed the submucosa. Yeah. That I'd say is number one.
Err on the side of going into the lumen.
Yes, if you can. Now I will say right off the bat though, if you have a special type of suture, right, and we'll get a chance to talk about this, whether it's reverse cutting, taper, all of those different types of needles. If you're using a taper, the taper will tell you. The taper will tell you. Yeah, the taper talks to you.
Have you ever found I find no use for tapered needles.
If I found one that talk, I would find a use for it for sure. 100%. Yeah, but I've yet to find that one.
I don't even buy them because I'm like, whatever, reverse cutting. That's all I need in the cupboard. Because have you ever tried to sew skin when they give you a tapered needle? It's super annoying. Okay, but you're saying there's a reason to get tapered needle. Tell me what it is.
Well, here's the deal. Now you said, hey, I don't find a reason to use tapered needles. And I'd say after this conversation, you may only get tapered needles.
Wow, okay. This better be some knowledge, Corey. You're setting yourself up here. You're
going to rock my world, Dr. Campbell. Okay.
I tell you what. Okay, that's a little bit of an overstatement. You're definitely going to need your reverse cutting, but I'd say anything under the skin, you can pretty much use a tapered needle. Now, here's why. Because the tapered needle will push the tissue away, and it's less traumatic versus a cutting or a reverse cutting, which obviously cuts the tissue. And a lot of people, which is interesting, may not know the difference between reverse cutting or cutting, but we'll talk about that later. But I'd say anything under the skin, I would use a taper. Now, there are people, when they're doing an intradermal or a subcutaneous, they will use a
reverse cutting.
They'll use a reverse cutting. And
yes,
I will say this. That's fine. That's completely fine. But I tend to use a taper because you just have to finesse the needle a little bit. But at the end of the day, here's what I think it's important to know. You can use taper underneath the skin for tough tissue, skin, ligaments, cartilage. You will need some type of cutting.
Are you scared to say those things? You gotta say that louder, man.
Let's do it. Let's do it.
It's like a big secret.
High decibel levels. Here we go. Everybody adjust your equalizers. Anything under the skin, you can use a tapered needle. Anything that's tough, ligaments, cartilage, tendon.
That's a taper?
A cutting needle. Okay.
Oh, cutting. Yes, thank goodness.
So softer tissue taper. Now, while we're on it, what's the difference between using a cutting and a reverse cutting needle? You guys are cool with that?
Yeah.
Okay.
Tell us anyway.
I don't know the difference. I hope you're going to answer your own question. Yeah.
Oh, no. Listen, because both of you, I want to talk a little bit about
here we go.
What your experience in surgery, but we'll get to that a little bit later.
Thanks,
because I know both of you are way more experienced than you're letting on, and I appreciate you feigning like you don't know, but I know you guys are awesome surgeons. For the sake of conversation, you're pretending you don't know. I will say that reverse cutting, bottom line is this. The apex is different. So if you look at arrows, right, you have an arrow pointing to the left or an arrow pointing to the right. A reverse cutting needle, the arrow would be pointing towards the needle. So the apex is pointing towards the needle. So that when the suture pulls, it's pulling on the flat part of the triangle. If it's a cutting needle, it's pulling towards the apex or the point of the triangle, which, of course, it's going to pull through. So
that's less than ideal.
Increases the likelihood it's going to pull.
Yeah.
All right, listen, you guys delved off into all kinds of detailed stuff. I want to kind of back it up a little bit. Okay, is that all right? Can I pull you guys out of the rabbit hole for a second? You mentioned something that I want to get into. So you said it takes. You said I'm not even listening. I'm just going to keep going. You said it takes courage, right? You got to have courage. You applaud the courage. But guess who doesn't have courage besides me? I'm going to go ahead and put that out there before you answer. Besides me, when it comes to surgery, there's a group of students. I mean, they're not students anymore, but they were just students yesterday, right? They don't have courage when it comes to surgery. I'm talking about new grads or people that maybe were out of practice for a while, like me. So what can you suggest to them? How can they get said courage or confidence when it comes to surgery? Because it's a real problem.
It's a real issue.
Yeah. I don't know the exact technique that's going to work for everyone, but there is something that seemed to work for me. And this sounds super bizarre, but I would, when I was in junior surgery, I would read about the procedure. I would do the procedure. And then for some reason, I would go back and read about it again. And for some reason, that second time reading it after having done the procedure was the clincher. It just seemed to allow me to visualize what the heck I was doing. And that's part of the process, is being able to visualize. So step one, to gain more confidence in surgery, read. Don't be afraid to crack the book out. Like I said, I could be doing this for 25, 30, 40 years. I will still break the book out. I'll break a journal out, and I'll try to, and by then, I know a lot of people listening are like, books, man, we just watch, videos, YouTube.
We watch the YouTube.
There's a YouTube.
Yeah. What are you talking about? Books, man, old man. But the truth is, I think
boomer.
Yeah, exactly. But videos are great too. But surgery is not a spectator sport. So you've got to really do it. So that's, I'd say, number one. Number two, don't be shy about practicing. Whether you are doing, let's say, minimally invasive surgery like laparoscopy or arthroscopy, you can certainly do what we call pepper arthroscopy, where you're, you sticking an arthroscope in a red pepper and trying to pull the seeds out, or those sorts of things.
Oh, I get it. I didn't know where you were going to go with that. That's pretty cool. I love it.
Right, or you're suturing.
I thought maybe surgery was spicier in Ventura. I didn't know. Like, what's happening here?
Jalapenos.
Jalapenos.
So I would say that don't be
jalapeno business.
Jalapeno business. Oh boy, nacho cheese. So I will say that don't be afraid to suture lettuce. Don't be afraid to suture pig skin, leather. Well, a lot of people have access to pig skin or those sorts of things, but leather. And you say, well, I feel like I'm going backwards. Like, this is what we did in junior surgery. Practice makes perfect. Of course, these materials do not have the same handling characteristics like actual animal skin, but it will certainly help your fine motor skills. Mm-hmm. And then what would I say would be the third thing to help people gain their confidence? Always see if you can have a great mentor. As far as see one, do one, teach one, if you're not comfortable, for the sake of the patient, for the sake of your own anxiety levels, just say, hey, do you mind if I scrub in with you on this one? Even if you have to just take an hour out of your day or schedule it nicely, just make sure that you get a chance to see how it's done, see tips and tricks, hand position, and their favorite things. If you can do those three things, read, practice, and find a good mentor, your success in surgery is going to be amazing.
Yeah, so, I would agree with the last one for sure.
Yeah,
okay,
so
not the other two. Okay,
no. So sorry. That's what I sound like. I of course agree with the reading because I like to read or watch videos or whatever. But the big thing for me is to have somebody to, for lack of a better term, like we've been using. But in all honesty, call, because once you get in, right, you're gonna have to get out, and sometimes things go wrong. So
absolutely.
Yeah. But I think it makes a difference who your mentor is and how they mesh with you for something like surgery, because it is very scary. The first real into a cavity surgery I did after graduation was a week out, and I was the only doctor on it at emergency practice because I somehow skated through an interview and they hired me. And a big giant pyo came in number one, I thought I was a rock star because I diagnosed the PIO, because that's hard. Yeah. That's not hard, right? And my boss at the time, she became my mentor because when I called her, I said, hey, so a surgery came in, and of course, we're still seeing patients. And she said, I'll come in and see patients.
You're doing the surgery.
And I said,
what?
I said, but you're not going to do
there.
the surgery? She said, no, I am not. And she refused to come into the surgery room while I was there doing it. So what she would do is she would look through the window and she would talk to me through the door, because she said, I'm not coming in there to do it for you or to help you. You can do it. And I had the book. The technician, I sucked up all her support staff. I had a technician holding the book. I had another technician helping me. And then I had another one there just to tell me nice things, right? So I could get through it.
Just a confidence booster.
Yes. But it was great, because if she had come in there, I probably would have used a crutch even longer than I needed to. But she could only do that because she was confident that she could clean up whatever I might have messed up.
Yep.
I think that, yes, getting kind of thrown off the deep end, so to speak, into a big surgery, it may seem unnerving, but I don't think she would have done that unless she had, like you said, the utmost confidence in you.
Yeah, I don't know how she knew that. We'd only met each other for 10 minutes, but I think she just plain was stubborn and refused to do that. No, I'm just kidding. She was the practice owner. So whatever mess happened fell on her anyway. So I think your point to a mentor is great. And I think people these days don't necessarily understand that mentor, you have to mesh. They have to understand you and what you need, and you have to understand what they are able to provide. Yeah, so that's a great tip too. So, all right, so we get to this big thing because there's always a choice, because in the cabinet there's like a bazillion choices. There's all these boxes with sizes and needles, and there are still practices. I know it doesn't happen there in the ivory tower for a board certified surgeon, but they do still have suture without a swedged on needle.
You know what? See that we're gonna sort of swage versus the real. Listen, I'll be honest. The real. If you've got suture on a reel, you think, oh, Courtney, you have no idea what that's like. Fortunately, I've had some beautiful experiences doing mass surgeries for, the underserved
for NGOs or something.
Yeah, exactly. For underserved communities or for the economically disanfranchised communities. And, the suture will come on a reel, and you say
soaking in what I think is alcohol, but I'm sure it's not.
Right. It's like, whoa, we just took a step back. But you know what? Dr. Jen, those dogs and cats, they do fine. And as long as the technique is okay, having it, whether it's swaged on or a reel, is fine. Now, let's be clear. There's a difference. When it's on a reel, you have to make the knot yourself. And so you're pulling suture through tissue. It's more traumatic. And then you're burying a lot of suture, which is something we don't like to do when we're making knots. So I don't want to go to gloss over the fact that there's some clear differences. It's slower. There's a bigger knot. It's more traumatic. But when used appropriately, they're going to be fine.
Okay. All right. So I also want to get into this issue because for me, like the organs are the same. They just might be in somewhat different places depending on the species I'm working on. Right. And, I've already decided my approach because I read the book as was recommended by my friend, Dr. Courtney Campbell. And so there I am, and I'm picking my favorite suture, and it's absorbable, and I'm rolling along. I got the mass out of the intestine. What's the fancy word for that when you cut the intestine?
Oh, it's an anerotomy. Yep.
That's right. Thanks for the doctor word.
No problem.
So I get the sock or whatever the dog ate, and I sew it up. And at the emergency clinic, because everybody knows that's what I like to do, it was referred to me because earlier in the day, they weren't quite sure that there was a foreign body, even though the dog hadn't eaten for 4 days, no more puking for 3 days, and no poop for 5 days. They just weren't sure. So to use up 5 hours of the day so they could refer it to me, they did a barium series.
Okay.
And I used a type of suture that has 3 initials and is my favorite because I'm very comfortable with how it knots and lays down and, that sort of thing. And did you know barium will eat some sutures?
Now, did that happen to you?
Yes.
Oh boy. Sounds like you may have used polydioxone with barium. Now, I will be completely honest. That is an interesting phenomenon that happened to you. And I have seen some intestinal surgeries where PDS is used and a barium series has been performed. And fortunately, they did not fall apart. But I'm sorry
because they didn't go into the lumen.
They didn't go into the lumen.
That's
there
right.
you go.
I can guarantee you I went into the lumen because
Now that is what I call a callback. You just took something we had talked about earlier and you brought it to the forefront. Genius. I love it. And you are dead right. I think that's exactly what may have happened, where you erred on the side of trying to get that submucosa. Unfortunately, some of the
it wouldn't leak.
Wouldn't leak. Exactly. Some of the suture went into the lumen and it may have broken down. And among the things that can be the most irritating to the intestine, barium is certainly up there among all the things that can do that. So unfortunately, now how did that patient do? Okay, or
oh no, totally did fine. Look, Dr. Courtney, as the Candyverse is well aware, no creature that I touch ever dies or remains ill. I touch them, and then they're cured with TBV, which is touched by vet.
There you go. Cured by Jen Chatfield. Yeah, and I'm sure you kind of cut in between the blood vessels so nothing ever bleeds or anything like that.
Not reptiles.
There you go. There you go.
Listen, I think my job in this is to just pull you guys out of this hole. You guys go find something, go way down in this hole. I gotta pull you out. I gotta get you out. All right, here, I'm doing it again. I'm tired of doing this. But can we talk about the different kinds of suture? We kind of mentioned one or two. But is there
let's do it. I'll flip it on you.
Let me tell you.
Okay, here we go.
When I first started, we had reels, 100%, right? There's cat gut or steel. That's what I had. Is there more?
He's older than me. That's why.
Yeah.
Yes. Well, okay. First and foremost, I think a lot of people ask, well, what suture material do you use? What's the difference between absorbable and non-absorbable?
Right. So let's go there.
My question is, for you, if you, and it's just a poll, I just want to take a poll from both of you. By the definition of non-absorbable suture, if you're thinking to yourself, non-absorbable suture, is it something that does not lose tensile strength greater than 30 days, does not lose tensile strength greater than 60, or greater than 90 days? If you had to pick 30, 60, or 90, by the definition of a non-absorbable, what would you pick?
60.
I think it never loses strength.
60.
Never loses strength. Right. That's the fourth one. Exactly. Right. I would say the correct answer is actually 60 days. Yeah.
No,
does not lose tensile strength for greater than 60 days. Now, there are non-absorbable sutures that by definition that actually do get absorbed. Right. And one example of that is silk. That gets absorbed over 2 to 3 years, but we classify that as a non-absorbable suture because it doesn't lose tensile strength for greater than 60 days. So just in a very sort of crude and basic way I can put it is, if you want it to stick around for a long time or forever, of course use non-absorbable. If you're sewing together tissue that likely heals very quickly, then it's okay to use, something that's absorbable. So as an example, if you're sewing together intestine, and particularly small intestine, that's going to really gain its strength, a large, not 100%, but a large amount of its strength within the first 10 to 14 days.
Yeah.
And so using something like, polydioxone or polygurcaprone, a lot of people know them by their more common trade names. But if you're using something like that, then you can sew it together intestine or even bladder. Bladder heals incredibly quickly. And so some people may argue that some absorbable sutures disappear too quickly and others stick around too long. So, for instance,
that's what I was just going to ask you about. Like, are they all created equal, or what's happening?
Not quite. Like, as an example, you brought up polydioxone. So if you go into the lumen of the bladder using polydioxone, there's a high likelihood that could serve as a nidus for infection or as a nidus for stone formation. So number one, if you're using polydioxone on the bladder, think about a different suture. Think about polygurcaprone or something that absorbs a little bit faster. So that's number one. Number two, stay out of the lumen, right? And again, it's all about submucosa. And then number three, just make sure that you're not putting in a ton of suture, because what we've learned is that simple continuous inverting patterns just in the bladder prevent you from having to use a simple interrupted, pick up the bladder, put the needle through, and just a lot of tissue handling. So if you can minimize those three things, then it'll work out just fine. And
for those of us who don't have any patience, simple interrupted is annoying. There's lots of knots. I can't make them lay down how I want. They won't listen to me.
Not pretty.
Yeah, they're not. And I like things to be pretty when I finish them, because you know what? The only thing a client sees is your suture line.
Well, let's talk about it. A lot of us have been trained by some amazing surgeons, right? A lot of them are a little bit gray-haired, have grizzled beards, or slightly older people in general, guy, girl, whoever. And they were taught with certain techniques. For instance, when you're closing the linea or the abdominal wall holding layer, the linea alba, a lot of them use a simple interrupted. And what we know now is that...
Not this girl.
Okay. And what we know is that there aren't increased complications by using a simple continuous. So if you're comfortable using a continuous pattern, go ahead and use it. Some people say, well, shoot, I heard that if you use if you're suturing, you should be able to pick the dog up off the table by how deep those sutures are in your linea alba. They don't need to be that deep. They don't need to be that strong. All you need to do is just make sure that you gently oppose the tissues, make sure it's secure. You definitely don't need to do some of those, what I would describe as not necessarily more antiquated or ideas of suturing. You know what I mean? So
like giant bites. Yeah.
Giant bites, lots of suture material. And it's, again, these people that we learned from, our mentors, fantastic surgeons, but the techniques have evolved.
Now we know better, so we can do better, right?
I like that. Very succinctly put.
So what's also interesting about that for our friends in the Candyverse, the news hounds that are listening, when we're talking about a simple continuous, it looks like a whip stitch. If you sew, it looks like a whip stitch. And if you are thinking about a simple interrupted, that's just every stitch has a knot.
Yeah,
so
you
hit
it right on that. You hit it right on the head. What's interesting about a simple continuous versus a whip stitch is that a simple continuous, you are advancing your suture on every other bite. A whip stitch, you are literally advancing your suture on every bite. Does that make sense?
Oh, so maybe we do simple continuous differently.
Well, no, that's fine. And you know what? It all that matters is that if things work out well and heal well, so we can go back. But I would say, and shoot, maybe I may be doing it wrong. So, but my point is, my point is, when I'm doing a continuous, I like to get both both bites on the same plane, and then I'll advance, and then get another bite on that plane, and then advance, and then get another bite on the same plane, and then advance.
You guys, listen, hold on.
Yes, go ahead.
I really wish, listen, I'm going to interrupt. This is fantastic. I really wish the Candyverse could see you right now. You are so excited to talk about this stuff. It is your passion. This is why I want to remind everybody, this is why we're talking to you. You are fired up to talk about a suture pattern. It is just amazing to watch.
Fired up, really ready to go, man. Ready to go. No, I'm kidding. I'm kidding.
But do you have, listen, this is probably a silly question, and from a non-surgeon, I'm so sorry. Do you have a favorite pattern?
Wait. Let's take a break.
Okay, fine.
Let's pay some bills. On the other side, Dr. Campbell is going to answer Dr. Jason Chatfield's question and tell us his favorite surgical pattern. All right, so we're going to pay some bills. We'll see you guys on the other side.
Suture material is not created equal. Absorption rates, material profile, and needles all have specific indications. Selecting the proper suture can dramatically change your surgical outcomes. Smart selections, quality choices, cost savings without compromise. Choose PRN Pharmacal. Visit prnpharmacal.com for more information.
Oh, sure. It's all fun and games until someone ends up in a cone. That's right. We're animals. Deal with it. Pet Life Radio. Let's talk pets.
Welcome back to Vet Candies and Other News, where we are talking with esteemed, world-renowned, and incredibly charismatic Dr. Courtney Campbell, board-certified veterinary surgeon. And Dr. Jason had a burning question.
I did. You ready? I'm going to ask you a different way, though, because
what's up?
So it's silly to say, do you have a favorite pattern? Because I'm going to guess you have different patterns for different kind of procedures and what you're actually working on.
Is that like different strokes?
Yes, for different folks, for sure. Listen, Courtney, is there when I was in school, it was the last time I did surgery, so it's a long time ago. Is there a pattern that you just have the most fun using? Right?
Yeah.
Not necessarily favorite, but the most, it's like just fun, right? It's
like
just
it speaks to you.
Yeah, kind of a fun pattern.
There's actually two. And nobody's ever asked me this question before. Everybody asks me, okay, Courtney, what's your favorite surgery? What do you like to do? And nobody's ever asked me, what is your favorite suture pattern? So listen, I want this to be a sort of a hallmark moment for everybody.
It's going to be for me, for sure.
All right, real talk. Here we go.
Our relationships will not be the same after this.
Everything changes after today. So I would say that, real talk, one of my favorite suture patterns is a forward interlocking. Now, a lot of people are like, really, man, you like an equine stitch in small animal medicine? And the reality is you do get the security of an interrupted, but the speed of a continuous. And, I know that there are some people, and this is sort of an obscure reference, but there are sort of veterinary dentists who will do extractions and prefer to use a forward interlocking. I've certainly used forward interlocking on feline skin because I find that it's a little bit more mobile. But then I'd say the honorable mention, or get second place, is something called an inverted cruciate pattern, which I think most either anybody who's ever had an animal or a pet who's needed surgery, or anybody who's doing surgery, closes skin with what's called a regular cruciate, which is just 2 bites, boom, boom, form a cross with the suture.
We see the X.
Yes, we see the X, and the X lays on top of the skin. Correct. An inverted cruciate pattern where the X lays under the skin. Now, you might say, whoa, Courtney, I thought you said you don't like you try to put as little suture under the skin as possible.
Yeah.
An inverted cruciate pattern does that. What's the deal? Well, here's the deal. You're going to take those out in 10 days. It's not
so you do
polydiaxone where you're burying a whole bunch of knots underneath the skin that have to get dissolved by hydrolysis. No. These, if you do this, the X underneath the skin, you get to take them out in 10 days. So that should work out just great. So
and
I would say
it looks super slick, right? Because you just see like the horizontal line crossing the incision line, and you're like, magic, how's the next one there?
You are very familiar.
I try to keep up.
You try to keep up. So I'd say forward interlocking, inverted cruciate, you got it.
Hallmark moment, only on another
Hallmark
news.
moment, only on any other news. So my question is, do you do both of those?
Wait, did he just ask us a question again on our podcast? We got to get him to read the rules of how this is supposed to work.
No, but I'm happy to answer
fascinated
that.
by both of you. I can't help it.
Okay.
I'm happy to answer that because I have a favorite pattern that I like. I do like a forward interlocking. I call it a blanket stitch because it looks like the hem, like where you put the satin on the edge of a blanket that's fancy. It looks to me like that's what it looks like in the skin. But because I can't be walking around saying stuff like forward interlocking. That's just not, like, people will be looking at me like I had two heads, right?
They do that anyway.
Yeah, but, as opposed to how they always look at you, right?
But my favorite pattern is actually an everting pattern.
Interesting.
So riddle me this, friends. And that's also because it's one of my favorite groups of animals to do surgery on, because I also cheat a little bit to make my field super clean, because I don't like blood in the field. It puts me in a bad light. I don't like it. I don't like to feel like I made them bleed. So you use an everting suture pattern. Do either of you know what class of animals you use an everting suture pattern on?
Let's hear.
Jason, do you know?
What class of animals?
Yeah.
That we use an everting stitch pattern on. So something that the skin needs to be everted. I have no idea. Get to it.
Reptiles.
Oh, I did know that, actually. I mean, okay. I was told that. Well, how about let's go with I was told that once or twice, but I couldn't recall.
Yes, because if you do scale to scale, right. So their skin, when you cut it, and if you try to oppose it, number one, it's really tricky to oppose it. It tends to curl in. And if you sew it, so you won't get apposition. Right. But if you not sew it, if you suture it,
correct,
scale to scale, it won't heal. Like, you could take those stitches out and like guts will fall back out. I shouldn't laugh. That's a bad outcome. Yeah. So you do an everting pattern so that you smash that mucosa, or whatever the fancy name is for the tissue right under the skin in a reptile. You smash it together and then it'll heal. And it looks really lovely. It looks cool.
Yeah. Well, always important.
Yeah.
I'm also curious, when we talk about cyanoacrylate, or basically skin glue, I'm curious to know if you have seen that used on reptile skin, because I believe there was a a study looking at using skin glue with
inflammation.
Inflammation, particularly in reptiles or like ball pythons. Have you any of you used skin glue with
I don't.
With snakes or any reptiles?
I don't, and I can't remember what that paper said, but I think actually that I'm trying to remember. I actually thought that it was either equivocal inflammation or suture was less, but I can't remember for sure. Do you remember the results of that?
It can cause inflammation. You know, it's a barrier to healing, and it doesn't really. It doesn't have the holding power that of a 3.0 or 2.0 that you would typically use. So I tend to veer away from skin glue in most settings. But shoot, you brought up a great point, man. When you're trying to do surgery with reptiles, then you've got to think out of the box. And so,
you know that you didn't ask me yet. As a surgeon, I think you would inquire, like, how do you not have blood in your field?
How do I not have blood in my field?
Yeah, I said I really like to do surgery on that class of animals because I can really, they're not like cats, right? Cats don't really bleed, right? Yes. But reptiles will bleed, right? So how do you keep blood from being in your field? This is like Aunt Jen's tip for great surgery.
I would just, with reptiles specifically or in general?
No, reptiles.
Oh, you got to cool them down, right?
So number one, you can cool them down, but already you're what?
You got to cool them down. That was Courtney's answer. You got to cool them down.
Your surgical suite should already be cool, like cooler than usual, because you want to like do that so you don't have germs and stuff. But already, like reptiles are already contaminated, right? We already know they have salmonella and stuff in the coelomic cavity, which is their belly. So who cares? But I try to put an ice pack between my surgical field and the heart.
Oh, wow.
Because it shouldn't be there very long. Don't kill me on the internet for that because it shouldn't be there for a very long time. But anyway, so I
got to look that up.
Yeah, so there we have it. One more very quick question for Dr. Courtney Campbell, and I know you can answer it in 10 seconds or less. When is the time to refer to a surgeon, like a boarded surgeon? When am I going to refer to a boarded surgeon?
Can I answer this question?
You, man.
Okay, every time. Okay, you go ahead and answer, Courtney.
Every time. No, for real. Anytime you don't feel comfortable. You know, I did get a call about a young pit bull who unfortunately had a urethral obstruction and couldn't pee. And I was speaking to just a really talented vet, and the vet said to me, the owner's having trouble, as far as deciding should she go see a surgeon and whatnot. And I was thinking about going ahead and doing making a new opening to the urethra, which is called a urethrostomy. She says, I've never done one before, but I saw it in a book and I can just go ahead and do that. And I just thought to myself, man, all the uretherostomies that I've done, it takes a high level of technical expertise. I'm sure there's people out there who have just done them once off the book and it turned out great. And I say kudos to you. But if those are the types of situations that are extremely obvious, if you've never done one before and you just are going to dive in, I would say be very, very careful, refer in those situations. And the other option is if there's an option. If there's an option for a boarded surgeon, I do believe that, the standard of care is to at least discuss that.
You got to offer it, right?
You got to at least offer it. Make sure that you make a record of it. And if it's with your conversation with them, and you two come to some meeting of the mind and they say, I would like to, decline that option, that's fine. But I'd say when to refer to a surgeon anytime you feel uncomfortable. And shoot, let us feel uncomfortable.
That's every surgery for some people.
Yeah. Pretty much I answered that already.
There you go.
Okay. Well, this has been wonderful talking about one of the most anxiety-producing things we have to do as veterinarians, and we do it every day.
And it shouldn't be.
But it is for a lot of people. And this has just been wonderful. You gave us some tips, especially for those new grads who are wondering how to get comfortable. We appreciate that. We talked all about suture, what to use when, the fact that there are different degrees of absorbable suture. So you got to pick the right one for your procedure. Like, what is it? Short, intermediate, and long, I think, for absorptive.
Yeah, we can just say, we keep it super simple. Absorbable versus non-absorbable. Just like that. There are different times for sure, but I like the way you put it, which is like, make sure you pick the right suture for the job.
Yes. Exactly. And also then when to not only phone the friend, but phone the friend to let them know that you're sending the patient over for surgery, right?
Give us a call. Yeah.
Give us a call. That's right. So once again, thank you so very much, Dr. Courtney Campbell, for joining us. We so much appreciate your calm wisdom
Oh man, I tried to be calm, but Dr. Jason, man, he got me out of he ruffled my feathers, man. I had to come out. So no, seriously, I'm totally kidding. You guys are fantastic, and it was awesome being a part of your podcast. I hope we get to do round 2, round 3 about just suture and our experiences, and we'll go back and forth because this is a conversation I think is really important to have.
Wonderful. Yeah. So did you hear that, Jason? He's going to interview us again.
Again, he's going to interview us on our podcast.
That's right, on our podcast. Anyway, thank you so much for joining us. This has been another episode of Vic Candies in Other News.
Let's Talk Pets, every week on demand, only on PetLifeRadio.com.